Thanks. Thanks so much for having me. So I'm going to be talking about one of my favorite laser devices, the fractional CO2, and how we can combine it in everyday use. How do we move forward? Oh, thanks. These are my disclosures. I consult for some of the laser companies and skincare. So fractional ablative laser is a very useful tool. We have the fractionated carbon dioxide laser and the fractionated erbium, but obviously any of these procedures can become fully ablative with enough density and too many passes if there's a lot of overlapping. So it's really important to stay consistent, set yourself up well, get comfortable, make sure the patient's comfortable, and then you can provide a nice treatment. CO2 provides combination of ablation and heat to the dermis, so ablation and coagulation. Erbium YAG is more ablative, but there's less penetration, so the epidermis becomes more of a barrier. But I always say good pre-op makes better post-op, especially if you're combining treatments, right? So once you start combining treatments with your fractional CO2 laser, the outcomes and the endpoints may be a little different. So if you're doing injectables, you want to make sure they understand the expected outcomes of each procedure, and when you're combining them, you may get a little more synergistic swelling, a little more erythema, so you want to know what to expect. So I always show them, or I try to show them, photos of what they'll look like, set expectations and downtime. And of course, preparation. Anytime we're doing these procedures, we want to make sure the canvas is completely cleansed. I use a chlorhexidine prep unless they're allergic to chlorhexidine, though in certain areas, such as like in England, I believe the chlorhexidine has alcohol in it, right? So obviously if we're also treating with a laser, we don't want to ignite anything. So I also use an alcohol prep, and I'll go over a study that we all did on this panel about combining therapies and what people are doing across the country. But basically I do a chlorhexidine prep, topical numbing. I give oral analgesia, acetaminophen and NSAIDs do a great job with combination. Of course, you can give opioids beforehand or something stronger, but even the combination of acetaminophen and NSAIDs do very well, and then nerve blocks, which we just showed. And then post-laser care, I heavily rely when I'm doing fractional CO2 on acetic acid soaks. So half white vinegar, half warm water, 3 to 4 times per day, and they're really soaking. That acetic acid kills Pseudomonas, which can just populate and live on our skin. Definitely an occlusive moisturizer in the beginning, first 48 to 72 hours, but then switch to something lighter so they don't break out. So this is about combination therapies, and Jen just did an amazing job. But sometimes you don't need combination therapies. Sometimes fractional CO2 does a lot. So this gentleman was bothered by his infraorbital hollows, his dark circles. He came in for filler, but in essence, he really didn't need that much filler or at all. So this is just before and after one session of fractional CO2. It's a pretty, aggressive treatment, but you could see the results that you're getting. This is, after a few months of healing, which it looks great. He was extremely happy, and no surgery and no injectables. Same with these infraorbital, like fine rhytids that people complain about all the time, the crepiness of them, and that you can, consider doing. I do neuromodulator in the orbicularis oculi, and then, filler is tempting to fill in some of these lines, but if the person doesn't have like really great dermal structure, that filler can show a little bit. So just using a fractionated CO2 laser, you can really tighten up that skin. Like Jen said, she prefers to tighten before filling, which is great. So those are just some examples of non-combination treatments, but combining treatments sometimes is more necessary. So this is a patient with Erdheim-Chester disorder, a very rare histiocytic deposition disease, and she is like extremely bothered by these periocular plaques, and it's not, even though the rest of her systemic disease is responding to her targeted therapy, the skin is not. So I do a combination of surgical excision, but layering it with fractional CO2 at the same time to really help improve the skin texture and to get rid of some of these histiocytic depositions. And so you can do this if you're being mindful and not using too much of a high density on the flap area or the surgical site. It helps the skin to heal without causing wound dehiscence, which obviously is our main caution. Injectables and CO2 go hand in hand. This is a great patient in her 40s, former smoker, admitted to tanning bed use and still loves to tan, now, even though she's had some skin cancers. She's also bothered by atrophic acne scars, her photoaging, her rhytids, her volume loss. So this is a typical patient that we see, right? All of the above. So combination therapy is really the mainstay of this. And of course, there's medical management as like topical therapies. And she was on low-dose isotretinoin, so about 10 milligrams every other day. Again, there are good studies and good consensus papers showing that you can do fractional ablative lasers while on isotretinoin, right? It's still not necessarily contraindicated, but still not advisable to do fully ablative CO2 while on full dose isotretinoin, but low dose and fractional is okay. In the same setting, also doing botulinum toxin, HA fillers, and then fractional CO2 laser. And you can see I also did some vascular laser there, so you can see the purpuric areas layered underneath the CO2. And then, they love to send selfies while healing, which is good because you want to see the healing process. And, with this combination treatment, you can really address a lot of their pain points. Again, the downtime is more significant, right? So many of our patients just can't afford this downtime, but the results are very nice when done in a layered approach. And the upshot is I always do the fractional CO2 last, right? It buys you time while they're numbing and while they're to do the other procedures before. So this gentleman, again, same concerns. So we did botulinum toxin. So after I cleanse the skin, I do their botulinum toxin. Then I can do their HA filler. And then I place the numbing on. So the numbing is going to give you about 30 to 45 minutes of time after you're doing those procedures to look for any tissue changes. It also gives you time for the botulinum toxin to actually uptake into the muscle, right? So theoretically, the botulinum toxin takes up into the muscular synapse quite readily, and then doing the fractional CO2 laser on top. Again, same thing just with PLLA filler. And this is again, just the progression of CO2 laser healing. And I like to show this as well because you can see not only how crusted and erythematous it gets, but at 142 hours post-laser, there's still erythema. So that's the point. Like, you want to show these patients that there's post-laser erythema. It's an expected response. It's not an adverse event, right? Lingering erythema is expected, especially in people who have rosiatic backgrounds. And then we can go for topicals. So this is just hypopigmented scars, really challenging to treat, but using a combination of fractional CO2 laser and then topical bemodeprost, which is it's topical that we use to grow eyelashes, right? But because it can stimulate melanocytes, and we know this because in the trials, they don't want it to get in the eye because it can change your eye color from light to dark. So it has been shown to stimulate melanocytes, and we can get some repigmentation of the hypopigmented area using the CO2 laser plus the topical bemodeprost. I also do fractional ablative augmented PDT. So this is a patient who's had like numerous basal cells on the face. She does not want any more surgery. So we do fractional CO2, but in a low density and low fluence, right? Because we know from great studies by Murat Hedestall, who's here at this meeting, low density, low fluence ablative lasers can help really deliver topicals through the skin and into the dermis, right? So you don't need high energies and you don't need high density to just deliver topicals. So this is just ALA delivered. This is laser fractional CO2 for radiation fibrosis and lymphedema. So this patient still is undergoing lymphedema therapy, but the addition of the fractional CO2, because there was a great study by Karen Connolly and David Ozog showing fractional ablative lasers restructure the vasculature in the dermis and potentially maybe the lymphatic drainage system. So that's the theory working behind using this for fibrosis and lymphedema. Same thing with this. This is radiation fibrosis. So this is a combination of botulinum toxin, very dilute botulinum toxin like Dr. Hibbler showed, plus CO2 laser, plus some vascular laser, just to help improve the pliability of the skin and the flexibility. And then last but not least, you can all read this in LSM, but Dr. Watchmaker and Dr. Hibbler and I, along with Allison Dempsey if she's here, we just surveyed laser experts to see what their practice patterns were. And I suggest, just reading it because it's helpful that it's in the literature, because everyone does things a little bit differently, but if we have consensus, we have good things to discuss and to fall back on. Most people will cleanse with alcohol. Again, it's flammable, so make sure it dries. The second best was chlorhexidine. And some people are using this hypochlorous acid. Most people give antiviral prophylaxis for ablative laser procedures regardless of the cold sore history. So even if your patient doesn't remember, most people are giving antiviral prophylaxis. Am I okay with time? Okay. Roughly half of those people give the antiviral course for a week, right? I tend to give it until re-epithelialization occurs, right? So if you have an aggressive CO2 laser and you're not fully re-epithelialized until 14 days, I keep that antiviral prophylaxis on because you really want re-epithelialization. More than half of the people do not limit the antiviral prophylaxis just to the perioral area. So if they're doing, periocular, they still give antiviral prophylaxis. And then majority do not use antifungal, so I think this is a good thing. Most of us are not using antifungals, and if they do use antifungals, all the people were using fluconazole as prophylaxis. I tend not to use antifungals unless they're immunosuppressed, which some of my patients are, and usually at that point they're already on prophylactic antifungal. And then for ablative lasers of the face, a majority in this study actually did give antibacterial prophylaxis. So I think this is an interesting point. I tend not to just readily give antibiotic prophylaxis because I rely heavily on the acetic acid wash, but I always tell them to follow up with us because any first sign of like impetigo or any sort of bacterial infection, I have a low threshold to start. And most people were giving doxycycline, which is also anti-inflammatory. So that's interesting. And then more than half just applied plain old petrolatum to fractional ablative CO2 area. So it's very occlusive. It will keep water trapped onto the skin, so most people are doing that. And a majority do not prime PIH-prone skin. So this idea of priming the skin to reduce the event of hyperpigmentation or post-inflammatory hyperpigmentation, it was split. It's not that much of a difference, but 54% did not. But if they did prime, then most people are using the triple therapy of hydroquinone, a retinoid, and a steroid. And this is what I use beforehand. Many people, a majority of people, are comfortable using a vascular laser as well as a Q-switch laser following botulinum toxin. So the botulinum toxin first, followed by a Q-switch or vascular laser. Most people are comfortable doing that. And then most people are comfortable doing vascular, Q-switch, and fractional non-ablative lasers following filler to one anatomical area. And then this is just another paper that Brian and I published using the FACE-Q, which is like a validated patient satisfaction measure. And we discussed the use of combination treatments with the FACE-Q, and our patients were very happy when combination treatments were done. They were even more so happy than just when the individual treatment was done alone. So I think, Jacqueline, thank you for putting on this combination therapy. It's really fun to talk about how we can combine lasers with all the other devices we have. Thank you so much.